Okay, good morning, ladies and gentlemen. Welcome to this Health and Wellbeing Board meeting on Thursday, 9th of November, 2023. Speaking about 9th of November, I heard it in radio this morning. 9th of November, 1812, Napoleon decided not to invade Russia because Russia was having the worst winter, I was told. Minus 37 degrees for 27 consecutive days. I thought today, well, weather as well as well-being and health can play a role in history. So here we are going to discuss about health and well-being. There are three major items, and all the documents have been prepared meticulously, I believe, and we are here to receive your comments and suggestions. Now, as ever, we will start the meeting by introducing ourselves to everyone so that we know each one. My name is Paul Edgell-Shelvin, Councillor for Clamlington South East. I chair Health and Wellbeing Board.
Graham Sayers, Clinical Lead at the ICB Northumberland.
Good morning, everyone. Jill O'Neill, Executive Director, Public Health, Communities and Inequalities for the Council.
Abby Conway, Chief Exec of Citizens Advice, representing Thriving Together.
Wendy Patterson, County Councillor for the Long Houghton Division and also portfolio holder for Caring for Adults.
Good morning, I'm Brian Mulder. I'm Senior Business Development Manager at Newcastle Hospitals. I'm representing Victoria McFarlane-Reid, who sends her apologies.
Morning, everyone. I'm Jeff Watson. I'm a County Councillor and Cabinet Member for Healthy Lives.
Good morning, everyone. I'm Glenn Sanderson. I'm leader of the council, and I apologise I have to be away by about 11:15.
Hi there, Jim Brown, Consultant in Public Health, Northumberland County Council.
Morning, I'm John Lauder, Consultant in Public Health at Northumberland County Council.
Good morning, I'm Jane Lothian, and I'm here representing Northumberland Local Medical Committee on behalf of Hilary Snowden.
Hi everyone, Neil Bradley, Executive Director for Adults at the Council. Thank you.
Morning everyone, I'm Ashley Eist and I'm the General Manager for the 0 to 19 service in Northumberland and Gateshead for Harrogate and District Foundation Trust, and I'm representing Russell Nightingale.
Hello, my name is Christine Wardlaw. I'm a pharmacist and I'm representing North of Tyne Local Pharmaceutical Committee.
Good morning, Cherie McCartney, Group Nurse Director for CNTW Mental Health Trust.
Good morning, I'm Veronica Jones, Councillor for Ponteland West and Portfolio Holder for Improving Public Health and Wellbeing.
Morning, I'm Alistair Blair, Executive Medical Director at Northumbria Healthcare.
Morning everyone, I'm Graham Benning, I'm the Chief Fire Officer at Northumberland Fire and Rescue Service.
Morning everyone, Audrey Kingham, Exec Director for Children, Young People and Education in Northumberland.
Good morning, Graham Wright, Director for Children's Social Care, Young People and Families at the Council.
Good morning, everyone. I'm Yvonne Hush. I'm a Public Health Manager at Northumberland County Council.
And I'm Kerry Lynch. I'm Senior Public Health Manager. I'm here to make a presentation today.
If you have laptops, we are being live recorded, so if you have a laptop or mobile phone showing, falling onto the camera, it might be seen, so be watch out. Okay, apologies for absence.
Apologies from Victoria McFarlane-Reid, Russell Nightingale, Councillor Simpson, Hilary Snowden.
Thank you.
Chair.
Yeah.
Could I also make apologies for Rachel Mitchison?
Oh, Rachel Mitchison.
Thank you.
Thank you. Minutes of the previous meeting on 12th of October. The minutes have been circulated. Can I accept that this is a true record of what happened? Thank you. Thank you. Item 3, disclosures of interest. Anything? None recorded. Thank you. So that brings us to the first major item, midterm review of the Northumberland Joint Health and Wellbeing Strategy Theme empowering people and communities. I think Karen McCall is, oh yes, you are there. Sorry, I didn't see that. Yeah, thank you.
Thank you, Chair, and hello, and it's a great pleasure to be here presenting on this. As has been outlined, this is the third presentation that's come to Health and Wellbeing Board around the refresh of the Joint Health and Wellbeing Strategy. And I know that at the previous meeting in October, my colleagues John and Jim, who are in the audience today, presented on 2 of the themes, and my other colleague Liz is presenting on the 4th theme in December's Health and Wellbeing Board. So I'd just like to take you through the refresh and the review that we've looked at in relation to empowering people and communities. Just for a little bit of context, and I will run through the first 2 or 3 slides. As I've said, empowering people and communities is one of the key themes within the Joint Health and Wellbeing Strategy at the moment. And the ultimate aim of the strategy is around improving life expectancy, healthy life expectancy, and reducing inequalities, and also closing the gap around inequalities. The theme itself, as it stands at the moment, the outcome for that theme in the strategy is that people and communities in Northumberland are listened to, involved and supported to maximise their well-being and health. And when the strategy was drawn together in 2018-19, some key priority areas were identified, and some local areas of action visible in those cogs there were set out. And I am going to come and talk more in detail about those as we move through the review, and share some of the thoughts that and reflections that we've had in pulling the review together about the existing strategy. So who's been involved in this? As with the other themes, we have an elected member representative, and Councillor Caroline Ball has been our elected member representative, with my colleague Jill O'Neill, Executive Director of Public Health Inequalities and Stronger Communities, as the lead officer. Myself and Abby, who's in the room today, have taken forward this review with our colleagues from the VCSE Inequalities Task Force. And throughout the summer, Abby and I have facilitated a number of workshops, bringing those colleagues together, having some really healthy discussion and debate. We've then gone away, corralled all that information, and the information has been presented back to the group, who are happy for me to present on their behalf today. So what we would like to discuss today, and really welcome your comments on, are the midterm progress against both the national indicators set out for this theme and those local areas of action that were identified. We do want to reflect on the impact of external factors such as COVID-19. We have got some proposed principles and priorities that reflect more the current landscape and the terminology and language of community-centred approaches and strength-based approaches, which we feel has moved on in the initial 5 years of the Joint Health and Wellbeing Strategy being in place. And then, unlike some of the other themes which have been presented this far and are due to come, rather than minor changes to this theme, what we are proposing is that rather than this theme remaining a standalone key theme within the Joint Health and Wellbeing Strategy, that it is actually an enabling approach that is adopted within the other 3 themes, and that moves forward as being very much a way that the other 3 themes work moving forward for the remaining 5 years. I have had conversations with the other 3 theme leads. I am aware that those themes are already working very much in this way. And when we come on to talking about metrics, we have had some conversations about whether this would be a feasible approach to take forward. So I appreciate this is a very, very busy slide at the moment that's up there in front of you. What I wanted to do was set out, as I say, that first point we set for discussion was looking at the midterm progress against the national indicators aligned to this theme. In the first numeric column, the grey column there, those are the benchmark indicators, if you would have, that were in the original Joint Health and Wellbeing Strategy. The second numeric column there shows where Northumberland has moved to in that period of 5 years. So those first two columns enable us to look at Northumberland's progress in comparison to where it was in 2018-19 to where it was in 21-22, which is the date that we have the data for. And I do want you to bear in mind that that 21-22 date that we have the data for, I feel is quite relevant when we're getting into the discussions about the value of these national indicators and our metrics. What I've then done is I have colour-coded, so anything that's colour-coded in green shows an improvement, and anything that's colour-coded in orange shows where no improvement has been made or there is a slight worsening in progress against those indicators. So what you do see there is that in comparison to 2018-19, the 2021-22 data for Northumberland does show some progress in 2 areas, but there are 4 areas where we aren't able to show improvement. Taking that in context and looking at where we are, what I do want to do now is look at the end 2 columns there and look at where Northumberland, those end 2 columns, anything that is shaded in green there, is where Northumberland has an improved rate compared to both the North East and to England averages. So whilst we haven't seen an improvement against all indicators over time for Northumberland in itself, we are seeing that compared to the North East average and to England averages, Northumberland is very much ahead of improvements there. We have better improvements than the North East and the England averages. What I would also like to say is that for many of our indicators, I think for 3 out of the indicators that are there, when you look at the ranking of the 152 local authorities that are compared within this data set, Northumberland for 3 of those is in the top 17%. So whilst over time in Northumberland, we don't look as positive in comparison to other areas and other local authorities, it is a more positive perspective. What I do want to talk about here is the usefulness and the relevance of national indicators, particularly when we're looking at this theme, which is around empowering people and communities. And also for me here, this is where the timeliness of the data is particularly relevant. The timeliness of the data here that we have available is for 2021-2022. That is at the point when we were just beginning to emerge from the COVID pandemic and from the restrictions that were placed on us around lockdown, social isolation, those sorts of elements. For me, this is particularly relevant in looking at this theme because we're looking at people's sense of control, people's sense of resilience, people's sense of empowerment. And I think that that time frame is just a time frame when people possibly weren't feeling massively positive in relation to their resilience, empowerment and sense of control. There are a couple of other caveats I'd like to link into the data, and I know my colleagues Jim and John both discussed these in relation to previous themes. One of those being that the national data very much doesn't give us a granular level detail. It masks variance across Northumberland and across our population, and it masks differences in inequalities. Also, looking at this theme, a lot of the data that is collected, we're talking about some of our vulnerable residents being those that are sort of providing the data into this. Much of the data collected may depend upon digital access and also literacy levels. So I think there are a few caveats when we are looking at the national data around these indicators. And for us as a group who've worked together looking at the future of this theme, that is one of the areas that has supported our decision to propose to yourselves that we actually move from this being a standalone theme and that community-centred approaches is very much an enabler for the other themes, which will then be able to demonstrate improvement on indicators that are more specific to those themes. So just going back to our local areas of action and what was set out in this theme in 2018-19, the ambition for this theme was to move away from a culture of preventing illness and promoting wellness and to a culture of doing to rather than doing with. It was very much about moving forward from a more than medicine approach and very much about 5 areas for action. And again, these areas for action were set out prior to COVID, but they are very relevant at the moment as well. Those areas of action focus on developing asset-based community development approaches, raising awareness among our frontline staff of where to refer into and where to signpost, and that understanding for those assets in our community. It's very much about promoting intergenerational approaches and very much around workforce development. In undertaking the review, we wanted to just set out some reflections on our thinking as we've looked at the theme at the moment and the progress that we've made. We certainly felt as a group that all of those different areas of action, what we said we were going to do, really had a single focus around creating the conditions that are necessary to foster at-scale transformation and a system-wide culture shift towards a strength-based, community-centred approach. We felt that those areas of action required long-term commitment, they required the system to work in different ways, and they required trust and different working between our partnerships and between our, ourselves, our voluntary and community sector and our communities. We also felt that we have moved some way in relation to that, and I know in the report I've set out a great long list of some of those enablers that have come into place since 2018-19. Those include our Northumberland Inequalities Plan. They include the wider rollout of Making Every Contact Count. We have Frontline as a single point of access, a single reference point for referring and for signposting. We have Thriving Together, working with and supporting our voluntary and community sector. There is multiple and numerous and diverse community connector roles within our communities. And then at some of the more sort of specific intervention and activity level, we have our holiday activities with food programmes, we have our Safe and Well visits that the Fire and Rescue Service carry out, and then we also have our Northumberland Communities Together programme within there. Because of the diversity and the scale of the work that has been implemented and taken forward in the early part of the strategy, that does throw it's really rich and it's really positive, and I think it really demonstrates a progress, but it also throws up some challenges about how do you measure that and how do you successfully measure at scale something that is happening in multiple different organisations and different areas across the county. When we did start to look at this, we did ask that sort of question of if we're able to throw a net over everything that's happening, how do we then pull that together? Where do we start and where do we stop? And one of the things that we do want to reflect and are happy to have a discussion about is that richness and scale and diversity of work carried out by multiple organisations mean that there are multiple systems of data collection, multiple different data sets. Much of that data is collected at a granular level, which is what we would want because it's happening in a local community or it's happening around a specific target population group. But that then really throws up a challenge of how do you pull that together and get some sort of sense at scale around that. And I know that a lot of those programmes that we've discussed, and again the report alludes to this, are already presented and come regularly into Health and Wellbeing Board. So we just wanted to say we looked at it, we decided it was a very hard thing to do, and just wanted to say that, you know, being able to have that collective understanding is very difficult. It is something that we are looking at the moment, and as part of Northumberland County Council's community first approach to taking things forward, we are looking to better understand our community connector roles, who is working in that landscape and that space with our residents, and also how do we bring those data sets together. So it is something that is moving forward within this second part of the strategy. We also looked as a group at the language of the strategy and very much felt that we wanted it to be more active and less passive. And I think that is also a reflection on time and where we have collectively moved to as a system over the 5 years, that we already are having different conversations as organisations with each other and with our residents compared to where we were 5 years ago. There's a couple of slides, and I'm not going to go into details of these because they are in more detail in the report, but this is just to say that as a group, irrespective of whether empowering communities and people stays as a singular theme or does become that cross-cutting enabler, we wanted to tease out some of the language and terminology that sat within that theme. I think a big thing for me around this is that if we look at the outcome that the group are proposing, that all communities in Northumberland are heard, understood, empowered and have an active role in optimising their well-being and health. That does sit as being very different to the original outcome for this theme, which was that people and communities are listened to, involved and supported to maximise their health and well-being. So it really is that shift to empowerment and ownership, which sits well within our inequalities plan when we're thinking about, what is it our communities can do for themselves, what might they need a little bit of support with, and what are the issues that organisations need to take forward. Again, we just set out as a group some principles there around what we would like to do. And I think for me that they're all very important, but the bottom one is really key to our working going forward, which is about making every door the right door. So whoever our residents come into contact with, we know that there will be an equitable offer and an ability to support that person's needs. So just onto my final slide, and the slide which sums up where the review of this theme would like to see this theme going forward. As I say, we feel that this is an enabling approach, that particularly the work around our inequalities plan and all of the organisational plans for partners across the Health and Wellbeing Board and our other partners across the system have inequalities and empowering people in communities, community-centred approaches as a key driver within there. We feel that there is much evidence for community strength-based approaches as a way to improve life expectancy and improve healthy life expectancy and make an impact on inequalities. We're absolutely passionate that empowering people in communities should not be diluted if it is moved away from being a standalone theme, and that it should actually be strengthened. Our proposal is, as I say, that this moves to be an approach that the other three themes take forward. And again, I go back to my point that many of the actions within those themes are already taking forward this approach. So it's really just strengthening that. And what we would like to do with the board's consent is work with our colleagues who are leading on those other themes and look at some metrics within those themes that link to the long-term healthy life expectancy and inequality metrics within those themes that we can support them to be able to deliver by taking forward an empowering people and communities approach. And I think I'll pause there. Thank you.
Thank you very much, Karen. It was wonderful, especially the visual slide is really capturing. Yes. Are there questions for Karen? Yes, Alistair.
I really welcome the report. It's excellent and I think very clear. The bit that I suppose I was just slightly struck by was the permanent admissions to residential and care homes. I completely support initiatives that maintain independence, particularly where individuals want an autonomy. I have some worries that the idea that care homes are bad intrinsically is wrong. I have some worries that given our population in Northumberland, which is skewed towards an over 65 and an over 80 population, if we approach the England average, and we're not far off it now, we actually are disproportionately saying that we have a much lower rate of our elderly population going into care homes. There are a number of individuals where it's absolutely transformative for often the last few months of their life. You've got to bear in mind 50% of care home residents are dead within 12 months. So there is an issue between people who are there a long term and actually the majority who are sadly not there a long term. So I just want to make sure that we get that narrative right. And actually my question is really, how much is too low? If we approach the England average, is that actually doing our population a disservice? And we also need to be cognizant of the fact that there is an economic factor, particularly in Northumberland, where we've got higher rates of local authority funding rather than private funding. And I presume the figures include private funding within that. But we are slightly skewed to the national picture of having more local authority funding and actually paradoxically more need within our population. So I just think it's worth thinking, because the corollary of that is actually we have people spending the last 2 months in a hospital bed dying, or the last 2 beds isolated on their own, very, you know, and neither of those are necessarily as good.
Yeah, I don't know if Neil wants to have a comment as well, but for me this is the trickiness of national data sets, first of all, and the way that things are measured, isn't it, Alistair? And also this, the premise behind the indicator was those who need to be in a care home should be in a care home, and we shouldn't ever think otherwise. And I hope I'm not speaking out of turn there, for, I'm sure Neil will correct me. But this links back to the Communities First work and trying to look at prevention in the community and reducing the escalation of demand so that there is the capacity for when people do absolutely the right place for them is in a care home, then that's where they should be. But Neil, I'll bring you in.
Yeah, thank you, Chair. I mean, I think Alistair makes a good point. I mean, I always like when we're talking about this subject, though, to differentiate between residential care and nursing care, because they're actually consolidated together in the numbers that we see here. I mean, I completely agree with Alistair that I think there is a place for nursing care and there will always be a place for nursing care. Even that in itself, though, is tricky in Northumberland's geography, because we can't offer nursing care in every individual community across Northumberland. So by moving people into that model, you can move them away from their family in that last period. But completely take your point, as opposed to social isolation or being stuck in a hospital bed, it's a much better option. There isn't a definitive line, though. I don't think that you can say that that is the right amount that we need. We know we need to bring it down. We are looking as a council and as an authority at more supported housing solutions, extra care solutions. We're trying to grow that option to keep more people at home. But I think Alistair's right. I think there is a tipping point where eventually the needs are such that the optimum really to give you the best experience in the final period of your life is to move into that supported environment. And I've had family members who've gone through that personally as well and would agree with that. So, yeah.
Yes, Jeff. Yeah, please.
Funnily enough, the one thing that I pulled out of this whole report was the same thing as you did, Alistair. And I looked at it and thought, that's really strange, where we have a much higher in the northeast than the national average, and a lower than the northeast, but higher, lower than in Northumberland. And I was trying to figure out why, and I suspect it's got to do with the basis of where we start from, the average age of the Northumberland population, and the geographical mix. And I think, if I understood what was being said, I think that assumption is probably right, and we think we're more or less where we should be. I just wanted to check that other people felt the same as me on that, particularly over there. Yeah.
I mean, at the minute, I would say we're a little bit higher than where we would want to be as optimum, and that's for two main reasons. I mean, one is the problems that we've got in workforce within the domiciliary care market at the minute, where we can't meet that need to exactly the levels that we want to meet, which means that some people are going into care homes, but we'd probably prefer to keep them at home, and that's something that we're working on as an objective to try and grow that workforce. And the other issue we've got is the pressure on hospital discharge that's coming down nationally at the minute, where, again, we don't have a domiciliary care workforce to get people back into their own home when we need fast hospital discharge because the hospitals are blocked. So they are going into care homes as an interim position, in theory at the start, but then often people become institutionalised once they're in there and they don't get back out of it. The family like the security of a care home once they're in there. but it does change your life outcomes really once you go behind those four doors of a care home. You know, your social group, your community that you interact with, or whatever, you lose a degree of that when you go in. So there are conditions at the minute. I mean, I think we're a little bit high, and it's why we've seen a slight growth in placements in Northumberland. We were on that slightly downward trajectory. We've seen a growth in sort of the last year to 18 months because of those pressures. It would be good if we could resolve the domiciliary care issues to bring that back to where we want it to be. But we're not miles out of line, I don't think, Jeff, would be my take on it.
Moving on to a separate theme, if that's all right. Thanks, Karen. That was really well summarised, and within it, it all resonated with what I know has been happening over the last year or two, and that's probably because we've all been integral to doing that side of things. From a system point of view going forwards, what I would just wonder is if there was any leaders in the room of organisations where the language and what's in there is a surprise or isn't quite what you understood. It's really a plea just to come and speak to us and get involved, because I know there are some organisations who have footprints slightly different to the core of Northumberland, where engaging with some of the meetings that we have is more difficult. But you're just as integral to the system, and therefore let's try and work on that if we need to.
Any other comments, questions to Karen? No. So as a board, we are being asked to recommend on the midterm progress described in that report, and also agree on the proposed amendments. Are we okay with that? Both of them? Yes. Thank you very much, Karen, for all your efforts. Thank you.
Thank you.
Good. Item 5, which is an update on tobacco control. So there again, from what I have seen, it's a very good news waiting for us, especially in Northumberland. We are the lowest in terms of smokers since the statistics began in 2011.
Everybody. Can I start?
Please
yes,
do,
thank you. Thank you.
I'm chatting to fill the gap.
Until we get ready. Thank you. Hello, everyone. I think you've met me before. My name is Kerry Lynch. I'm Senior Public Health Manager here at the Council, working in Jill's team. And the report that you've seen and I'm presenting today is one of Councillor Patterson's. She's the chair of the Northumberland Tobacco Control Partnership, but also comes under the wider remit of Councillor Jones, improving public health and well-being. So the purpose of the report that you've seen was to give you that update. We come on an annual basis now for tobacco control, and also to ask you for steer and guidance, make sure that we are on the right lines. Please permit me 2 minutes to remind us why this is an important issue. I know I've talked about it a number of times, but it does still remain the biggest preventable cause of death and illness in Northumberland, in the North East, in England. It is the leading driver of local health inequalities, and those harms fall on our most vulnerable individuals and communities. Smoking is still the UK's biggest preventable killer, causes around 1 in 4 cancer deaths, leads to 64,000 deaths per year in England, and it puts huge pressure on the NHS. Almost every minute of every day, someone is admitted to hospital because of smoking, and thousands of GP appointments can be attributed to smoking, equivalent to over 100 every hour. So there's no safe level. We can't do this in moderation. This is something that we need to continue to prevent, and that includes second-hand smoke, passive smoking as well. And those effects happen immediately. There are short-term effects, medium and long-term, and they include all of the heart disease and cancers that I've already mentioned. So really the kind of key message for us today is that we need to continue our focus and our drive. We can influence this, and it's a really ripe time. I will be mentioning today the national measures that have been announced recently. It won't have escaped your notice in the press and in the media and in the political arena. So I will mention that. I didn't know it all at the time of writing the paper, but I'll be talking about that in a second. But we can influence that. We can influence nationally by political influence, organisational influence. We can still work with our regional programme that we fund, and of course locally via the partnership and all of our organisations that are represented. It's a positive picture for us in Northumberland, and it's important for us to look at how much progress we've made. So at the last count in 2022, 9.6 of our adults in Northumberland are smoking, which is fantastic. It's better than the England average. It's the best in the North East region. However, I always have however. It still means in a population of our size, we've got over 25,000 smokers in Northumberland. We're such a big county. We still can estimate that about 500 people die in Northumberland every year on year from smoking, and that we experience approximately 4,000 hospital admissions every year because of people smoking. So it is positive, and we must commend ourselves and each other on the progress that we've made, but we need to keep the foot on the pedal for that. I do believe that this is the reason we've done so well is because we have always focused on smoking and tobacco. I really believe that it's because we've done so much work locally, and it complements that regional and national approach as well. I will be mentioning in a little while, though, again, the burdens that are on some pockets of our population. So I've mentioned just two there, and I've got a little bit of information in a second. Routine and manual workers, for example, people who are suffering from mental illness. And again, even that pocket of people, I know there's colleagues here from CNTW, it depends on what you look at. So people with enduring long-term mental illness or people with serious mental illness and acute, it doesn't matter. The prevalence is higher than is in the general population. And those figures are prevalence rates in those pockets of our communities that we haven't seen in the general population for decades, and yet they're still suffering at those levels. So just a bit of a background for today's update. You will remember that last year this board endorsed the development of the Local Tobacco Control Partnership, and you tasked us with a number of things. We were to progress the evidence-based regional 8 key strand approach, and I've put some of that in the paper, that we were to strive towards a wide range of agencies represented, and again in the appendices in the paper I've listed who we've got on that partnership, and we want to continue to expand that wide range of partners supporting the agenda, and that we would agree some focused action together, some collaborative action and work towards a shared vision. So I think all of that has been achieved in the last year, and this is the vision that is on the screen here. Northumberland children born today will live a smoke-free life. We aspire to reach a smoke-free 2030, where adult smoking prevalence is 5% or lower, and we'll work in partnership and we'll use that evidence-based approach to get there. So now is the bit that I'm going to stick in that I didn't know when I wrote the paper. So forgive me, but it's time is of the essence, and it's a really good opportunity to update you on this. The Prime Minister announced some of the most ambitious national measures seen for some years at the beginning of October, and that includes raising the age of sale annually, year on year. This would essentially mean that anybody who's born on or after the 1st of January 2009 will never be able to be legally sold tobacco. So anyone who's 14 years old now and under will never be able to be legally sold tobacco products. It's groundbreaking. It's huge. And what I want to say today is, we need to accept this and endorse it. And I'm going to tell you how as well in a second. There's also going to be, alongside that, a doubling of efforts around stop smoking support. So we will be getting some additional resource in for our Northumberland Public Health Stop Smoking Service. Even by 4 p.m. last night, this is out of date. This is how quickly it's moving. So we thought that we would get an additional 313,000 there into the council. It's actually a little bit more because they've looked at prevalence over a longer period rather than 1 year. So we'll get 366,000 additional. What we are tasked with doing is making sure that we maintain what we currently invest in stop smoking services, which we absolutely will. And then we'll be looking at this amount as well to augment. I think I'll go back onto the partnership and the focus groups. What I would like to propose, and we'll be talking with Jill and Jim about this, is that we need to target even more on some of those difficult to quit groups, which I've got on another slide. We will also be receiving some additional resource around enforcement to trading standards, HMRC and Border Force to tackle illicit and illegal tobacco and vaping. I have asked the question, I don't know again whether that's going to be based on prevalence or whether it's there's going to be another methodology used, whether it'll come straight to trading standards, but obviously I'm linked really well with that department and they will know. And also further proposals to tackle youth vaping in England, which I know is of concern. Those interventions are estimated to mean up to a further 1.7 million fewer people smoking by 2075. It will save thousands of lives. It will save the health and care system billions of pounds. It will boost the economy by billions of pounds. You know, I always say this, don't I? But I can't think of anything else that we can have as big an impact on as tackling smoking. So we're going to continue. And one way that we can start to influence this, and you can start to influence this, is to respond to the consultation that's live at the moment. So it went live on the 12th of October. It's open until the 6th of December. I've been discussing with Jill and Jim about getting as many responses to that consultation as we possibly can. Volume of support, particularly for that raise of the age of sale, is really, really important. So I'll talk about that in a second of how we can do it. So going back to us in Northumberland, what we've been doing with Wendy's Steer is working with partners to look at particular target groups. And I know we've mentioned before about, and Karen's presentation just now about inequalities. By default, smoking increases inequalities, but also, as I've said, within our population, there are certain target groups. And what I've tried to do in the paper for you is to say these are the key areas, and these are the things that we're doing about it, or that we propose to you that we would like to do about it. Young people, absolutely. Using some of Yvonne's in the audience today, Yvonne's work with the Health Related Behaviour Survey locally, we know that still the vast majority, huge majority, almost 100% of Year 6 pupils are not smoking, so that's fantastic. But we are concerned that, and have always been, that year on year prevalence rises with age. And that's why, again, the measure to cut that off, to turn the tap off of that in terms of legal age of sale is really, really important. And so locally we're looking, we're going to set up we haven't met yet, but a separate task and finish group to look at young people, but also to include vaping in that. It is slightly different. But we know that certainly partners in education and etc. are concerned about this. We've had feedback from schools that they are concerned about it. So we need to, I think, go back to where we were 20 years ago with smoking and really start to support young people's settings in schools around policies around vaping, to make it proportionate, but to make sure that they know how to support that agenda and to support the young people with it. Smoking in pregnancy. Again, we've made really good progress with smoking in pregnancy, and now this particularly is led by colleagues in Northumbria Healthcare through the NHS long-term plan. So Northumbria Healthcare maternity services have a best start in life pathway now. Every pregnant woman is referred to that, and they're seen face-to-face, either face-to-face where they are or in the family hubs until 28 days postnatally. And the team are seeing some fantastic results. It just shows that if we support people who are on their smoking, embedded into where they are and who they're seeing, it has some really, really good results. If we refer them somewhere else, there's a gap and there's a potential that they'll fall into it. So over the last year, that team in Northumbria Healthcare have seen 84 women set a quit date. 45 of them have quit for a short period of time. That gives a 53.6% quit rate. Now that's about average, but for pregnant women, that's really good. So it's really promising, and they want to focus more now, I think, going forward, correct me if I'm wrong, Alistair, is to look at the women who have very chaotic, complex lives, some of those, again, more difficult to engage pregnant women. Routine and manual occupations. Again, this goes back to what I said before. In this particular group of workers, We can see smoking prevalence at a rate that we haven't seen in the general population for decades. And my proposal and my appeal to all of us is we all work in a workplace. So this should be something that we should all be promoting to all of our workers around stop smoking support. And we can do that through different mechanisms that I've mentioned on the slide. And then lastly, but certainly not least, mental health conditions. People with a mental health condition have a higher mortality rate compared to the general population, and this is somewhat because of their physical health. It's the largest contributor to their 10 to 20 year reduced life expectancy, which it's not acceptable, and we all need to continue to work around that. I also mentioned in the paper a couple of examples of partnership work where we are addressing health inequalities. I haven't got a lot of time, but it's in the paper, and obviously you can ask any of us to expand. But we've been doing a particular piece of work with housing, made a good link with housing, and offering a bespoke behaviour and vape opportunity for those social housing tenants. The numbers are small, and that's okay, we expect that. But I want to continue to expand that by, and have already put the bid in, to the National Pathfinder scheme, which is where you'll have heard again about the government offering 1 million vapes available to smokers. Well, we've bid for that, and we'll hopefully be able to use that with some of these target groups. And also another example, a good example of partnership work through the group that Wendy leads is our link with trading standards around illicit tobacco. We have a particular role, a fair trade officer in the trading standards department who's been focusing on tobacco and alcohol prevention work with some really impressive outcomes here from that team. So you can see on the screen, resulting in seizures of over 33,000 sticks of illicit cigarettes over the last year, closures of premises found to be selling illicit products, and they're also working in a proactive educational approach as part of Operation Crackle. Now, these are things that Trading Standards were doing anyway, but it means that they have been able to augment and actually filter prevention work on tobacco throughout the whole team. So that's it really. I mean, next steps are we're busy with the tobacco JSNAA chapter. We have been using the health inequalities approach, the 3 questions, which isn't easy actually, and it has opened up a few gaps for us. We don't necessarily know as well as we would like what people actually are saying about tobacco and what have you. So we'd like to do a little bit more of that locally. All of that will be built into an action plan with Wendy's steer. So, but then the biggest next step that's time is of the essence is our response to the consultation. So if we can all think about making that response by the 6th of December, that would be fantastic. I've submitted the bid I've already mentioned, and I say the next step will be local planning around those additional resources that are coming in. I've put also in the paper some examples under the 8 key strands of the next steps that the partnership would like to take. So that's it. So my recommendation is, please, if you would note the development and the progress of the Northumberland Tobacco Control Partnership during the last year. Please offer suggestions to us regarding some of those emphases for the forthcoming year. If I can ask as a subsequent ask that wasn't in the paper, it's about responding to the consultation that's now live. I have asked about sending letters, and I'm not sure we're going to be able to, Jill, because there isn't a way that we can do that. So responses will have to go through the consultation document, but I can help with that. We can help with summary responses to that. But certainly, if the Health and Wellbeing Board will give sanction to the consultation, and for each of you as leaders in your own organisations to make responses, we're really keen to get that volume. I've got a little video. Fresh have been out onto the streets of Ashington and the beaches of Blythe to ask people what they think about a smoke-free generation. I thought it was a really nice way to finish today. It's only a minute, but it is worth watching. Makes Blythe look lovely. The beach looks smashing.
And I would worry if I see that they were smoking. Yes, I would. I've got 2 little children, and I would worry if I see that they were smoking. So if it happens that they grow up in a smoke-free society, yeah, that would be one of the best things in life, I suppose.
It's definitely possible, isn't it? Do you remember the smoking ban? Everyone thought that'd never work, and everyone just kind of fell into it, didn't they?
Yeah. Yeah, definitely, because it's better for people.
It would be fantastic to see that, and I hope I see it while I'm still alive.
I think that's great. I think it's a great idea, yes, aye.
That would be fantastic. I mean, just even thinking like the NHS, you know, thinking that way, the pressure off the NHS would be fantastic.
Just like my little boy, I want him growing up in a world where he's not having to be around smoke.
How old's your daughter? She's 12. And if she was to start, I wouldn't be happy.
Yeah.
Like, now looking back, when I was that age starting smoking and what, I wouldn't have it for my daughter, like, no way.
Yeah.
That would be perfect. Absolutely perfect. And I think in time, the longer that went on, then I think people just would not even be aware that it was ever smoke. I would like to think it would be nice there was a time when nobody was aware that smoking was ever a thing.
Thank you.
Thank you very much, Kerry. I mean, you are very passionate about it, and we could feel it, and there are lots of positive things, but still we have quite a way to go towards our target of 5% or lower. Thank you very much for the wonderful report. Yes, are there questions? Yes, Jeff.
First thing I would say is just before Glenn left, wrote me a little note saying thank you very much for the report. He really appreciates it and thinks it's very good. I have, forgetting Glenn now, this is me, I've got two questions. I think you mentioned that smoking was the biggest killer. Where does alcohol feature in that? And the second question is, are we sure this swap to stop with vapes is a good move? Are we then encouraging kids to vape? Do you think, or is it definitely going to be somebody that you can prove is smoker who then goes on to be vaping? Because there's a lot of questions, isn't there, about vaping? So there's 2 questions and one thank you.
Shall I take the second one first, and then Jill might answer? But the alcohol's not my thing, but definitely yes, it is still the biggest killer over everything else. But I'll answer the vaping question. We'll need to put some sort of measures in place to make sure that making sure that we're offering the vapes to adult current smokers. Because you're absolutely right, Councillor Watson, that there's a nuance here. It's different to smoking and tobacco as well. I said before that there's no safe way of doing that for anybody. But with vaping, it is a safer, it's not necessarily safe, but it is a safer alternative if you're an adult smoker smoking 20 or 40 cigarettes a day. So definitely we would rather they switch to that than continue smoking. But we don't absolutely want to see any non-smokers or definitely any children vaping. So the swap to stop won't be open to any non-smokers or any children or young people. And some of that, the Pathfinder work that I mentioned, where that's going to be on a national platform, we'll draw down our resource from that. We'll have to age verify anybody who's receiving that, but kind of just as we would with smoking and the support we give already. But you're right, we have to be careful, and it is definitely only for adult current smokers. Alcohol.
So I don't have data to hand, obviously, Jeff, but what I would say is that I would never want to try and compare tobacco to alcohol to obesity, because these are all really big public health factors that we have to put additional effort into all of them. But absolutely, the preventable causes associated with death, tobacco remain as number one. The harms caused by alcohol, while people are still alive, as well as the associations with death, are still uncomfortably high for us, and we are prioritising that work, but the number one remains tobacco, but we can provide more detail outside of here.
Yes, Wendy.
Thank you, Chair. Kerry, that was an excellent report and an excellent presentation and full of enthusiasm. And as the chair of Tobacco Control, I just want to reassure people that it is the most well-attended group of people that I've ever had to chair a meeting of. Our partners are so passionate about this. Trading Standard, as you mentioned, our colleagues at Fresh, we're all determined, very determined that we do our very best for the people of Northumberland. And early diagnosis for cancer is also something that we really need to look at as well. And we do have our NHS colleagues that attend as well. So thank you so much.
Oh, thanks for the chairing. I think I'm looking. I think everybody, and thanks to the board, because I think everybody who's here today has a representative, or pretty much. Maybe we need to speak to Abby, but I've got that in the paper actually, haven't I? Of we want to expand, but I know that you all endorsed this last year, and there are representatives from all of your organisations. Thank you.
That's it.
No, sorry, Veronica, sorry.
Thank you, and thank you, Kerry. So there's a couple of things really. The first one is about tobacco from abroad. If they're going to be restricting the sale of tobacco in this country, we're going to get more illicit tobacco, aren't we? I would have thought. And one of those is, I think, coming in. So I spoke to a smoker recently, in this building actually, about the price of tobacco and how on earth could, the price of it justify. And he just laughed and said, I don't buy it in this country, I buy it abroad and bring it in. And that's going to happen more and more. So that itself isn't illicit, but I would imagine that will follow on too. So are we able to boost our trading standards to that level? And the other one is on the consultation. It is important that we and as many residents as possible just get that sent in. So it's an ask. If it's possible to do a short why you should do this, because councillors and everybody else can pop it on their social media. But if it's easier to do it, if it's there in front of you and you can just cut, paste, pop out with how important it is. If you could do that, I think that'd be a really good boost of the response. So that's my two. Thank you.
Yeah, thank you very much, Councillor Jones. So yes to the second. We can do that. I say I'm a bit disappointed that we can't just sort of send our own responses in by letter, because that would make it easier. But we have to go through the portal, and there's 27 questions on there. But yeah, we can do a summary definitely, and a kind of this is why. The first question around trading standards, and you've seen that the additional resource that's coming in nationally is for border force, for HMRC, for trading standards. So I'm not the expert on those things, but I think that will cover the sorts of things that you're talking about. And in terms of sort of enforcement, we've actually got really good enforcement and regulations in this country. But I know on the webinar that I dialed into just this week with Professor Chris Whitty, somebody did ask, trading standards has always been, it's been a declining workforce. It's been a declining resource. So will the funding come to them? And I believe the answer was yes, and it will come to us in Northumberland for our trading standards team to decide how best to utilise it. But you're absolutely right. I mean, I think the other question it's sort of hinting at as well is, as we start to have less and less kind of legal tobacco, what does that do to a market and a kind of other availability? But actually, when I've read about this, when we've changed age of sale before and that sort of thing, it doesn't flood a black market because it's done so gradually. I also don't think it's a reason not to do it. But hopefully, Veronica, that national injection of cash will help our trading standards team locally to address that.
Thank you. You want to comment?
Thanks, Kerry. Really interesting. I'm wondering how we can coordinate our organisations to really enhance that making every contact count. I know from a primary care perspective, we identify people who are smokers and we offer and we make brief interventions and we refer to services. I've heard some examples for prescribed analgesia where people perpetually turn down the offer of intervention via pharmacists, for example. But when a joint approach is made by a social prescriber and a pharmacist at the same time to try and sort out some of the issues in life, such as housing or debt and things like that, at the same time, they suddenly become much more receptive to taking up the offer of doing the intervention. And I'm not sure if your teams work side by side with people, such as social prescribers or link workers, or whether it were actually just coordinating ourselves separately. So we all know we're trying to do it, but it's not a joint approach. And you might be able to give me examples of that happening, but I'm not aware of any.
Yeah, and I think we need to do a bit of both, don't we? So that everybody does need to be doing it independently and embedding the MEC, and I've mentioned that in sort of a next step for us as a partnership to actually do that in a more obvious way, like you say, Graham. We have had conversations with CAB around debt and linking smoking to that. And what I learned a lot from colleagues in that team, that there's quite a stigma when somebody is struggling with their finances, for example, and then for us to kind of have a conversation about smoking in that context would need to be really well thought out. Which wasn't new to me, but it was a different way of looking at things. Whereas I would always expect, because you can see that how passionate I am, that somebody would say, "Oh yeah, I get that," but actually, it's quite different. So yeah, we're just making some of those links with housing, with voluntary sector, with CAB that possibly, yeah, you're right, we haven't done as obviously before. So yeah, I agree, Graham. We need to do more.
Any other comments, questions? Yes, Jill, please.
Just want to echo thanks, Kerry. I think if you cut you in half, you would say stop smoking down the middle. So your passion drives us forward, so huge thank you. We can absolutely provide support in relation to completion of the consultation as well. Not that we want to steer too much your responses, but we can provide guidance because there are a number of questions, but if some things could be, oh, well, this could be an answer that you might want to put in, then we can support with that, can't we?
Yeah, the first 4 questions are the ones around raising the age of sale and do you agree or don't you agree? They're the really crucial ones. There's about 20 then on vaping and flavours and different tank sizes and fixed penalty notices and all of that, which other colleagues will have more idea of how to respond to them. But the first 4 are really, really important.
Yeah, I think as I was reading your report last week for the pre-meeting, I thought about the ban, Prime Minister's ban, and as you said, it's a really groundbreaking. I started looking back. When did we last abolish something starting from an age? Because we always reduce the age of voting and, that kind of a thing, or we have been admitting as a society. But this is the first time, after a long time, we are abolishing something for certain age groups. It will be like the slavery. The last thing I could remember was abolishing slavery all the time. It was very hard, and lots of people need to be convinced. And this is now being abolished for certain age group people, so that we can go into a smoke-free. So that's really a groundbreaking, intervention, and a healthy intervention. But it'll be nice to see how it pans out, how it gets enforced, and how the rogue retailers are being, handled or detected or something. So it'll be interesting to see. But nevertheless, it's a good start. Yeah. I think so. Thank you very much for all your report, for passion and everything. All the best for the future. Right. Okay. Oh, sorry, Abby. I didn't see your hand. Abby has a question. Must be a very difficult one.
Not at all. As a parent of 15, 13 and 10-year-old, the idea that they could never legally buy cigarettes is amazing. So I completely commend what you're doing and the chairing of that committee. And I'm more than willing to go out to the voluntary sector and see who really can talk to that topic and who's the best place to maybe be represented there. I think that's something that Thriving Together can absolutely do. So that's not a problem at all. And I echo what you were saying there about working with CAB colleagues and other colleagues around what's our role. because, you know, as an advice giver, and this is also with a lot of other voluntary sector organisations, you know, we never want to be in that judgmental place, and we never want anybody to ever feel, you know, that they're doing something wrong, because actually what that does is turn people away from those areas of support. But I do think there's a piece of work around communications, and so that we're all singing from the same hymn sheet. You know, some of the questions that were asked before about vaping and how safe vaping is, again, as a parent, that's a massive worry for me. My kids aren't talking about going and buying cigarettes. They're all the vapes. They're picking vapes off the street constantly, and all that sort of side of it. That's something that I think is the next challenge that we're really going to have to focus on. But you know, the question was asked about how safe are they and all of that sort of stuff. I think if we had a combined messaging that when people are coming to us with stuff, we can point them in the direction of where the support is, be able to access all of this additional stuff that's coming, which is marvellous. And it's that point that Karen was making and Jill have made around that no wrong door. If whoever sees that person or that family is able to put them in touch with, you know, the right resources to support them, I think that's how we crack it, really.
So while I've got you, I would appeal, please send somebody, a representative to the partnership, and then, you know, advise us. That would be really helpful. And I think it goes back to the MEC and getting that MEC message right as well. I don't think any smoker should be judged for their behaviour. It's just a fact, you know, and I think if we stick to facts and then we build those facts into the conversations that we have, judgment isn't there. It's not about that. It's about this is and this is what we can help you with. But yes, please send somebody and help us. Thank you.
There's one more. Thank you.
Thank you. I'm sorry for coming in late. I'm just sat reflecting on your presentation. It was fantastic. Thank you so much. From a mental health perspective, the figures, the percentage is staggering and isn't acceptable. I guess the thing that I'm sat reflecting on is where we focus our efforts currently and what needs to be done moving forward. So from an inpatient perspective, so for service users that may be admitted to our acute hospital sites, we've got really robust packages and a really robust QUIT team that supports the notion of swap to stop. The thing that I'm reflecting on just on the back of your question around making every contact count, I do think that there's further effort and focus needed within our community teams particularly. I think that those that perhaps work into primary care more actively, it is more of a focus, but it's just a commitment to take away to look at what the organisation is doing for this county and more broadly within our community team. So thank you.
Contribution to make, yeah.
Yeah, apologies, I'm now reflecting on others' reflections. I asked myself the question, and it's a rhetorical question, and it's maybe for board members to ask. I'm sitting here asking, do we talk about MEC, and then I'm asking myself, do we have MEC embedded into policy? And my answer in Fire and Rescue is we do. So we talk about safe and wellbeing visits, and we talk about what MEC is with regards to the policy statement, and then asking the question, if we have it in policy, how do we drive our policy towards being able to deliver what MEC means? And that means making sense of it to the operational staff who are going in and out of people's homes. So they know they're going in with their statutory responsibilities around fire safety, but then it's what does MEC mean, and how do we take the corporate commitment per department to understand what that means to our staff. So I'm putting the question out there to ask. We talk about MEC, it's integrated into an awful lot of the high-level strategy. How do we actually deliver it to make sense, so we're making sense of the stuff when staff walk into people's homes?
Any more? So that I don't miss out any. I don't see any. Thank you. Thank you very much for all your contributions. So that takes us to item number 6. update on promoting better mental health and well-being in Northumberland by John. Yeah, thanks, John.
Morning, everyone. I'm John Lawler, one of the consultants in public health, as have been introduced, and I'm here to provide an update on promoting better mental health and well-being in Northumberland. Perhaps a little bit like Graham has just said, he was commenting or reflecting on people's reflections. As I've heard the presentations this morning, I've been reflecting on my own kind of presentation, and hopefully people will be able to see links and some kind of clear themes and associations with the previous presentations. Excuse me. Where we're coming from in Northumberland is from a place where we've got a really strong partnership approach to promoting better mental health and well-being. We were one of the first local authorities, if not the first local authority within the North East, to sign the Prevention Concordat for promoting better mental health, and that was a commitment to focus on prevention and addressing the wider determinants of poor mental health, collaborative working between organisations, and about building capacity, and there was a toolkit which has been associated with that. So we're coming from a really strong place. When I was also reflecting on promoting better mental health and well-being, it's probably helpful at the start just to mention what that might mean. And in terms of public mental health or promoting better mental health and well-being, often we're looking at preventing mental health disorders from arising, promoting mental well-being and promoting resilience. And we can approach that at different levels, so that's a very primary prevention or a primary level, so promoting resilience in people who've got perhaps established good mental health, but also for each of those things it's important that they're available for people who at an early intervention. So if people are developing early signs of mental health problems, that we promote mental well-being at an early stage, and for people who've got long-standing or existing mental health problems, they still need support around promoting better mental health. I do want to make some really important acknowledgements at the start, really for Jane Walker, who's Strategic Commissioning Manager at the ICB at Northumberland Place, and Dr. Kathy Peterson, who's the ICB Lead for Mental Health, Learning Disabilities and Autism. They are absolutely pivotal in the partnership working, which is being undertaken within Northumberland, and they've been fundamental to producing this paper. Unfortunately, neither of them are able to attend today, but if they had been able, they certainly would have been here. And also to Yvonne Hush, who's Public Health Manager, and Pam Lee, Consultant in Public Health, who are the authors of the paper. Just as a reminder, I think it is important to go back just to remind ourselves about the importance of good health, mental health and well-being, and they are just some key statistics. These are quite dated now. They came from the Adult Psychiatric Morbidity Survey, which is undertaken periodically. I believe that that was due to be repeated this year, and would expect the results of that to be published in the next year or two. But at the time that this survey was undertaken in 2014, 1 in 6 adults were reported to have a common mental health problem in the last week. And that's reporting symptoms of something like anxiety or depression. They may describe it as bad nerves. So it's really common. Similarly, high numbers in children. And I think really significantly, 1 in 5 adults had considered taking their life at some point. And huge amounts of stigma, with 9 out of 10 people with mental health problems experiencing stigma and discrimination. As highlighted in the report, common mental health conditions were most frequently reported condition by people of working age who had long-term sickness. So really significant. And in terms of the importance of good public mental health, there's a couple of points on there that good mental health, as we know, it's associated with better physical health. We're often, and I think we still do, frequently discuss physical health and mental health separately, but we know that they are closely intertwined. You need one to have the other. And we know that people with good mental health have better physical health, increased productivity, they do better in education and at work, they have better relationships at home and in the community. And good mental health is a foundation block for resilient and strong communities, linking back to what Karen was saying in the first presentation. So it is a vital asset. It's fundamental to people having a really productive life and for overall quality of life. And we do know that there has been an increasing trend in common mental health problems reported through different surveys over COVID, and we know that COVID and the more recent cost of living increases have had an impact on commonly reported mental health problems. And we also know that there's a really complicated link with socioeconomic and other inequalities. Kerry had mentioned about the prevalence of smoking in people with mental health problems, so that's a kind of link with physical health and other inequalities. But we know that if you've got poorer mental health, any of those, or difficulties in any of those areas, so complications at work, at school, complications with relationships, affect your mental health, and they're both the cause and consequence. So it's a really complex link between inequalities and mental health, and we know that there are groups in society who are more likely to experience poorer mental health. I thought it was helpful just to outline for the board some of the key multi-agency partnerships within Northumberland, and I have broken this down possibly a little bit simplistically into adults and children and young people. Particularly with adults, there are some really strong partnerships, and that's the Crisis Care, Suicide Prevention and Mental Health Strategic Partnership, which is supported by an operational group. Both of those are thriving groups which meet regularly, and there is a Promoting Good Mental Health Action Plan which was developed during COVID and possibly as part of a response to articulate how that group was going to address and implement some of the recommendations from the Prevention Concordat, but also to tackle some of that increasing demand which was starting to be seen before COVID, but certainly was manifested through COVID and compounded by it. And within children and young people, there's an emotional health and wellbeing steering group, an operational group, both of which are multi-agency, and there is an emotional wellbeing and mental health strategy for Northumberland, which is a multi-agency strategy, which I'll talk a little bit about later. And closely linked to that, there is also a strategic partnership, and there is a local SEND strategy as well. So it's very important. They are very closely linked in children and young people. So the social, emotional, and other developmental needs are very closely linked to mental health needs as well. My thanks go to, as I said, Jane Walker and Kathy Peterson for this slide, because this highlights some of the partnership working. I can't go into some of this in detail just because of the length of time that we've got available and some of the huge amount of work which is being done already in Northumberland. But Kathy and Jane provided some key examples to pull out. There's the Community Mental Health Transformation Programme. This is a national initiative to transform community mental health for adults within the community, and particularly for those people with moderate to severe mental illness, not exclusively, but partly towards that group of people. The first thing I think really to emphasise is that the achievements are the product of this really broad and inclusive partnership. It doesn't just include healthcare partners, it includes the voluntary and community sector, what we call experts by experience, so they're people who have experienced mental health conditions, their family, friends and supporters as well. Obviously got primary and secondary care. We've got the Mental Health Trust, so Cumbria, Northumberland, Tyne and Wear Mental Health Trust are a fundamental and absolutely key partner in this, as are Northumberland County Council, and it's not just the public health team, it's a range of teams across the local authority, and there are other key partners, including the police and ambulance service as well. So what we're describing is actually a really broad partnership approach. And perhaps another element within the council is also Northumberland Communities Together, because it's really that reach into the wider community as well. As I said, Community Mental Health Transformation is a national initiative about transforming community mental health services and the experience of that. And perhaps one way to look at it is how would the experience, or how would people using those services experience them? And I think Karen had mentioned earlier about a no wrong door approach, and that's absolutely how it is. So there's been work to develop in partnership to develop an approach which is no wrong door. So wherever somebody comes into contact with a service, that's their point of entry and their point of contact. So whether that's in primary care or through the voluntary and community sector or through the acute sector, whether that's Northumbria Healthcare Trust or the Mental Health Trust, they will get to the right place. And there's partnership working to be able to facilitate that. And importantly, it's also linking physical health services with mental health services as well, so people aren't having to try and access different services at different points. And we've got a couple of examples which I'll mention. It's about, or community transformation is about bringing services closer to where people are. So people aren't travelling to a central base for services, they're actually being able to access services near to where they live or where they work. A couple of examples of that are the Community Eating Disorder Team, which is provided by CNTW, but actually close to where people live, so operating in the bases in Northumberland in the community, and that helps people to remain independent, reduces the need for hospital stays, and it helps people to stay, as I said, independent. There's the Hope team, which is helping overcome personal and emotional difficulties team. This is for people with relational difficulties, which would possibly previously been referred to as personality disorders. And they may be people who have difficulty in struggling or difficulty in managing very strong emotions and issues. And that provides online, telephone and face-to-face support for those experiencing difficulties, but also support for their families and supporters as well. And it's near where they live. And there's also Northumberland Recovery College, which is, it doesn't have a college base, but it provides information, learning activities and courses in community venues around the county, open to all adults who live or work in Northumberland, and it provides a range of support and activities, which are, again, it's linking back to promoting well-being, linking people with activities and hobbies, not just providing information and support about their potentially their mental health condition or the thing which they're struggling with. Some other examples of really strong partnership working are partnerships with the local authority particularly and other health partners to develop a dementia strategy. There's a dementia care home project which is using a specific dementia diagnosis tool to try and increase the diagnosis of dementia in people who are living in care homes, and that can actually help them to receive better care and providing support and advice for their families. And there has also been work as well to commission specialist dementia beds for residents of Northumberland. So that's some examples of some additional key partnership working. There's also a focus on urgent care work. Right Care, Right Person is an initiative from the police to make sure that people accessing care or support, particularly in crisis, actually are seen and responded to by the right person. There's the NHS 111 mental health option, and that's an initiative to add an option to the 111 telephone service, which will be specifically for mental health, and also work around mental health conveyancing. That's about transporting people, so not necessarily an acute ambulance service, but an acute conveyancing service. These are national initiatives. Some of them are in development, but they'll be implemented locally through that partnership. So it'll be the ICB and partners who actually make that happen appropriately at a Northumberland level. And importantly, there are alternatives to crisis, because historically people have presented in mental health crisis, as we know, to places like accident and emergency department, which are not the right place for them necessarily to be supported in a crisis. There is Together in a Crisis, which is a partnership with Mental Health Concern within Northumberland, which provides access not just to mental health crisis support, but to links to those other things which we've talked about. So links into the voluntary and community sector, links into, it might be debt or financial advice, because that might be one of the things which is precipitating or exacerbating a crisis. That's provided through Together in a Crisis on a 9-to-5 basis, but there's a partnership to develop a safe haven, and that's really a really mature stage of development. It hasn't been implemented yet, but there's a strong working group which will be, in a way, expanding that Together in a Crisis offer, so it will be available to people outside of normal working hours, so Monday to Friday during the evenings and at weekends as well. And that provides an opportunity both for health professionals to refer into that support, but for people to self-refer as well. There are a range of online resources in Northumberland, particularly Quell and Cooth. Quell is an online resource for adults and Cooth for children and young people, which provide both online support around promoting better mental health, promoting resilience, and for people with low-grade difficulties. And they're available free of charge to people. They don't have waiting lists, and they are evaluated really well. And finally on this slide, there's been the provision of post-diagnostic support for people with autism. So adults who receive an autism diagnosis receive the offer of a post-diagnostic course, which includes referral to voluntary and community sector organisations which can support them with that diagnosis and also provide information and support to their families. And as Kerry had highlighted, there are high rates of smoking in people with mental health, and very tenaciously, the Stop Smoking Service in Northumberland has developed a smoking cessation project for people with severe mental illness, which I think is now really starting to reap some really great rewards in terms of engagement of service users, getting referrals, particularly from primary care, and supporting people through that quick journey. There's a huge amount of work which is being done to promote good mental health and suicide prevention. There is a really comprehensive training programme which is provided through the public health team but available across Northumberland, and there are examples on there about mental health awareness, mental health first aid, both for adults and young people, and suicide awareness. And more recently, there have been some bespoke suicide awareness and mental health awareness sessions developed for elected members. There's a huge amount of partnership support for campaigns, and I can see Claire Malone from our comms team is sat in the audience. These are a flavour of some of the campaigns. So there's partnership support for things like Stress Awareness Month, Mental Health Awareness Week, some of the suicide prevention campaigns, and recently there was a Silver Sunday, which was, I believe, in Blythe or Ashington, which was incredibly well attended and supported by Adi Keogh from the Blythe project. And the ICB provides a huge amount of support for primary care around specific clinical support, I think, for people, particularly pick out improving physical health checks for people with severe mental illness. Over recent years, there's been a huge increase in the proportion of people on a severe mental illness register who've had the opportunity to be referred, have had a physical health check in primary care, which, as we've highlighted earlier, that's a group of people who experience much poorer physical health, and including smoking, and actually it's a fairness and equity issue for us. And last but not least, there's the Better Health at Work award scheme, which promotes the training offer, promotes suicide prevention training, and shares good practice through different networks, including large employers networks. And some of the key partners of the Health and Wellbeing Board are active members of the Better Health Award scheme, so particularly the two big trusts, so Cumbria Northumberland Tyne and Wear and Northumbria Healthcare Trust and Northumberland County Council. And that scheme provides support for businesses not enrolled in the scheme. As an example, within Northumberland Council, we have a comprehensive staff wellbeing offer, and that's linking back to promoting resilience, promoting better mental health, and preventing mental health conditions arising. There's a web portal and, as I said, a comprehensive offer which includes health and wellbeing support, financial support, psychological support, and support for managers as well. And I know that each of those key employers, so Northumbria Healthcare Trust and Cumbria Northumberland Tyne and Wear, will equally have their own staff health and wellbeing offers. So I think it's important to realise, and I think we did mention previously, that we are a big employer. We've got big employers represented around the Health and Wellbeing Board, and it's incumbent on us to actually make sure that we have strong health and wellbeing offers for staff. There are some key groups for who are perhaps more at risk, or we know tend to experience mental health in different ways. We know that men are 3 times more likely to die by suicide than women. And we know from experience that men tend to have different coping mechanisms and health-seeking behaviours, which has historically meant that they are perhaps less likely to discuss mental health issues and less likely to seek help for them. I've put a picture of Mind recently updated a survey which they undertook in 2009, and compared to the findings of 2009, the 2019 survey, the results of that did display some really promising changes, as in an increase in health-seeking behaviour from men, so an increased likelihood to talk about mental health problems and to seek guidance for them. That's only a small sample, but I think it's positive, and I think we'd probably all have experience and attest to the fact that we think that actually we are talking about mental health more frequently, and that's one of the ways in which we reduce stigma as well. There are some specific partnership examples within Northumberland to support men in particular. So there's a man's club. Northumberland Recovery College provides some specific support to men. There's a project within, I think it's in Berwick, which is exploring a social activity group for men with neurodiverse needs. And Similarly, the post-diagnostic support for autism will support men as well. Importantly, I've mentioned family hubs on there. Family hubs have developed really extensively over the past 18 months, and I think Graham Reiter may be updating the board at a future meeting about the progress within family hubs. But that is a really strong partnership collaboration between Children's Social Care, the 0 to 19 service within Northumberland, Northumbria Healthcare Trust, and particularly the Community Maternity Service and other partners. That's making use of additional funding which has been provided. The focus of some of that at the moment is around improving infant feeding and supporting perinatal mental health and parenting support. But a key element of parenting support is providing support to fathers, and there's a really strong partnership offer within family hubs which is aimed at developing support for fathers. And moving on to children and young people, I think I mentioned at the last Health and Wellbeing Board, we are aware there's an increased and sustained demand on services which started pre-COVID for mental health and children and young people presenting with mental health needs. And there's an increased complexity of needs and an increased number of children with social and emotional needs. There is a strategy within Northumberland, so that's the Northumberland's Emotional Wellbeing and Mental Health Strategy, which is a multi-agency strategy. You can see perhaps the partners who are listed on there just in their number. It's based on a graduated approach which is using a Thrive model from the Anna Freud Centre, which categorises perhaps mental health need and then tries to assign where services, including the voluntary and community sector, can provide support for children and young people with different levels of need. At the lower end, so around promoting mental health and early intervention, some of the key services are the 0 to 19 service, which Ashley's in the audience, and there's been a lot of work which has been done over the last 18 months to develop that service, and particularly developing an emotional health and resilience pillar to really strengthen the offer provided within the 0 to 19 service. There's some strong partnership working between family hubs and the 0 to 19 service in developing some group interventions, so things like Relax Kids and Charge Up, which provide resilience support for children and young people. I mentioned the Cooth online support. I'd also mention Northumberland County Council's ordinarily available provision, which is about provision of support for children and young people with neurodivergent needs and other needs in mainstream schools, keeping them in schools, in mainstream schools, and providing that support for them. There's been a review of the BU website, and that provides, or it's the portal for a huge range of that lower level of support for children and young people, including voluntary and community sector and online resources, and then linking into mental health support teams in schools. That includes primary health, mental health workers who support children and young people. We've got mental health support teams not in every area of Northumberland. They are in Blythe, Hexham, Ashington and Bedlington, but will be extending to Alnwick and Coker Partnership. I think that's probably in 2024. And we've got a really strong mental health support offer in schools. In addition to that, every school within Northumberland has got a senior mental health lead and there's a senior mental health coordinator. There's an extensive training programme which is really well respected regionally. I think it's been used regionally as a pillar of excellence. So there's a really comprehensive offer, and I've probably just only scratched the surface of it. What we do want to do within Northumberland is really build on the established partnerships and extensive collaborative working. And as I said, it's not just a collaboration between health partners. It's a much wider collaboration. Using those established and really strong partnerships to develop a promoting better mental health strategy for the county. And it does raise the question of what would a better mental health strategy or a public mental health strategy look like? And I think without preempting those discussions which we would want to have within the partnership, it's very much about preventing mental disorders, promoting mental well-being and promoting resilience, and perhaps looking at those 3 tiers. Certainly I'd expect that to be included and a core part of a promoting mental health strategy, but providing some strategic direction to capture all of that work which is being done and the partnership work in which is being done, and perhaps a promoting mental health strategy in other areas would link with and include those links to physical health as well. So have a holistic approach or capture at least those links to supporting physical health and well-being. And certainly for Northumberland, as I've highlighted, we have got a number of strategies, including a suicide prevention strategy as well. We wouldn't want to reproduce those. We would want a strategy to make links to those. So in summary, I'd like to just finish there. I think the key points for me are really to discuss and highlight that breadth of really strong partnership working which is already being undertaken, but to invite discussion about promoting or developing a promoting mental health strategy. Thank you.
Thank you, John. Thank you very much. I think as a board we are expected to comment on what the multi-agency work on mental health, and also comment on this development proposal for developing the mental health strategy. So are there any questions, comments to John? Yes, please, Wendy.
Thank you very much, John. Quite a complex report there. And I think there's a lot to be positive about. In particular, I do think that catching children at school is the right thing to do, and that prevents from going on into later life if it can be sorted out then. So that's a really good initiative. Thank you very much indeed for that presentation.
Thank you. And I would come back on that. It's a really important point to make that actually the majority or significant proportion of mental health conditions in adulthood actually initiated when during those developmental years, and actually strengthening parenting support and providing that support. So it's not just specifically about or things which we'd identify as being specifically to do with mental health. It's about the things which are being done in family hubs as well, and through children's services, about providing really strong parenting support as well. So thank you for that.
Jill?
Thank you. Thanks, John. It is really comprehensive. It's been important to pull it all together, because I think there's so much happening. Until you see that breadth, then you don't really know. You only know what you know, if that makes sense. I think there's something for me about the importance of a strategy, about there's loads of stuff, most of it's evidence-based, but what difference is it making? And do we want to amplify some areas and do less in other areas? And until we have a strategic approach to this, we won't know. So it's brilliant to see the amount of work that's happening, but being able to coordinate that to be able to then in a year's time come back here and say, and what difference is this making, will be really significant for us. So thank you.
Thank you. Graham.
I think it echoes what Jill said, really. There was so much there. It was almost how brilliant are we? Why can't we just go and lie down somewhere and have a rest now? You know, because there's so much in there. And I was actually really pleased when you got to your last slide, because all the way through I was thinking, but where are the gaps? What are we not doing? What do we need to be doing differently, and how will we do it? I didn't hear the word inequalities anywhere in amongst it. I think there probably was somewhere, but it echoes much of what we're trying to do. We know that there'll be certain groups are doing less well, and maybe there's something in that. And then I was thinking operationally, how do we take this, and if we do identify gaps, how do we work differently to then fill them? And that's when it comes down to our system board, where the group of more operational leaders sit there, how do the organisations then relate? And you've obviously got a very effective strategic partnership going on, but how does it then fit? How does the rest of the system know what's going on within that strategic partnership? And I know you're early on to the case in this, John, so I'm not expecting you to answer the questions today. They're more rhetorical questions. I'm not expecting you to come back with any answers there.
And I think they are really important points, and in terms of developing a strategy, there are things which will be fundamental to that. And I think you're absolutely right about inequalities. I did mention inequalities, but actually understanding that at a strategic level and really looking at the data to understand what are the impacts of inequalities and where do we need to really focus our efforts strategically, because as you said, there's a huge amount of really strong work which is being done. There's loads of really strong examples, but we need to challenge ourselves and ask what we're missing, what do we need to do more of.
That's a good point. Thanks, John. Yes, thank you, Graham. Yes, Abby.
Yes, thanks very much. It was really, really comprehensive. So much detail in there. I think one of the requests that I would make, and I think it's just what you were just talking about there around what else, within the partnership and within the voluntary sector organisations that you've been working with predominantly are mental health focused. That's what they do, whereas actually mental health and well-being is much bigger than that. And I would just really kind of ask to kind of how can we bring more voices into that, and how do we ensure that actually it's everybody's business and it's everybody's conversation in order to feed into the about all of the other themes really. So if you want to talk about that, I'm more than happy to think how do we not just bring people to meetings, but how do we disseminate stuff? How do we discuss and bring creative thought into it as well?
I think that'd be really welcome. Thank you, Abby.
Sorry, at risk of reflecting on more reflections of other people's reflections, it's a bit of a hall of mirrors, but I echo what you were saying before. We've been sitting here listening to these presentations and commend them all. I mean, we've had a very interesting overview of some very good positive reports. What I'm finding is that we actually are in an extremely good place, Graham. And your point about congratulating ourselves, we should sit back every now and again and think, actually, we've got a very coherent strategy. We've got a number of very coherent strategies. There's an awful lot of really good stuff going on here. From a Health Watch perspective, we were reflecting recently on how can we connect better with the communities, and I use that term in its widest sense. We had this conversation, didn't we, Jill? And it didn't kind of come out in that first presentation, so just my reflections on reflections from the first presentation. We should not lose sight of the fact that the communities we're trying to enable are not just about place. We've got communities of place, experience, identity, all those other sort of widest communities. There's an awful lot of initiatives going on, and that was very clear in that last presentation. Some of them are siloed and some of them aren't. Our strategy gives us a really strong framework within which to pull all that together. And there is always room for continuous improvement, so not in any way intended to be critical. If we're all asking, what else can we do, because that's in our nature, some of it's about connecting better, I think. Are there initiatives that we can connect up better? And the communities together is a really, really strong platform on which to do some of that. Connecting across the statutory and VCSE sector is fundamental. And doing that no wrong door even better than we already are. And we're doing it really well here already. I say this with a number of hats on, because many of you will know I also wear a veteran's hat. Timely, perhaps, to reflect this week in particular on the community of armed forces veterans who, particularly when we get into that mental health space, very, very small percentage of them will have particular mental health challenges. They're a particularly hard community to reach. as are men. So a lot of them are men. A lot of them are men who are probably even less likely to come forward with mental health issues than others. So I haven't really got a question. I'm just observing we've put ourselves in a really good place. I think we've got a really good opportunity now to build on that even better. And there are initiatives, that some of which we've seen on the screen. I didn't see inequalities up there, but it was implicit throughout. Because when we think about the inequality strategy, we are looking at hard-to-reach groups and inequalities across those as well. We've got the tools, we've got the sort of intellectual challenge we keep giving ourselves, and I think we've got an opportunity to bring some of that together. I think some of that answer is about just looking at those connections and how can we connect them up better.
So thank you very much. So if I get it, your point, there are lots of interesting points. So what you are saying is that we should be focused on connecting ourselves with the communities, in particular the veteran group. Is that your point?
Not in particular. I think we should be focusing on. We should always ask ourselves, with our inequalities hat on, we should always be asking ourselves which are the communities we're not hearing from.
Okay. Right.
Which are the communities we could connect with better, communities in their widest sense.
Right. Thank you very much.
How might we use, coming back to Graham's point actually, all the various contact points we have in those communities to connect up the messaging in both directions. So from a health point, how can we hear the voices of those communities better, bring them into this room to inform our decision making? One of those communities, but only one, and quite a small one, happens to be veterans, but it's relevant this week.
And Jim Brown. Yeah.
Thank you, Chair. I guess one of the things I'd like to do is to kind of connect up some of these 4 different themes of the Joint Health and Wellbeing Strategy that we're looking at. And we've now brought 3 of the themes to Health and Wellbeing Board, and the wider determinants of health and wellbeing theme will be coming subsequently. And also just remembering that actually mental health and wellbeing is one of the cross-cutting themes. And I guess in some ways maybe we intentionally actually, but it's the wrong way round, but intentionally. And I think the links between all of these, we need all 4 themes and all of the cross-cutting themes in order to be effective as a system to improve the health and well-being of our population, reduce inequalities. I think what we've already seen today and what we've talked about before, that if we don't get some of the structural determinants of health right around income, around employment, around housing and education, then it's going to be impossible to have good mental health. It's going to make stronger communities more of a challenge, and it's going to make healthcare and a whole system approach to health and care a distinct challenge. But equally, if we don't have strong communities where people feel connected with their wider community, where they can connect to the assets and the support and the services within their community, but actually feel empowered themselves, then they're not going to have good health and well-being. And equally, if we don't work together as a whole system and whole system approaches, then it's really going to be impossible to achieve that. But equally, just to reiterate what John said around, but if we don't get the best start in life right, we don't create resilient children, young people, adults, they can't have good mental health. And if we don't have good mental health, we're not going to have good physical health. So I think if we've got to get all of these different pillars, all of these different themes right, they link up together. We cannot see any in isolation. So thank you very much.
In fact, you've given an overall view of what we are trying to build in case of joint health and well-being strategy with 3 themes going across all other themes. Thank you, Jim. Any other comments? Yes, please.
Thank you very much. Thank you so much for your presentation. It is extremely complex and it was extremely comprehensive. I guess I don't know that I've got much more to add on top of the points that have already been made, but I think that the strategy influencing the groups that are already sitting is absolutely crucial for the success within the county. There was a really interesting point, I think, around I guess the employers that work within our county, and just thinking around the wellbeing strategies that we have in place for them. So I would like to just think about how that can be developed some more as part of the partnership, and learning from good practice. I think the end of this year, the turn of next year is going to be incredibly important for some of the initiatives. So the Right Care, Right Person that's due to launch around about the 11th of December. We've got Safe Haven that's due to go live the beginning of next year. And I guess one of our huge challenges for our organisation specifically is the community transformation and how that, I guess, rolls out in partnership. I'm just kind of thinking around how we're measuring ourselves and how we're measuring our effectiveness and direct feedback from the communities in relation to some of these really important projects. Thank you.
Any other comments?
No,
sorry, Graham. Yeah.
DWP didn't get a mention, John, in there. And I'm thinking employed and I'm thinking unemployed and the economically inactive people, and how many of them mental health contributes and how many of them may not have access to mental health services or support. And I'm assuming they're somewhere in the strategic way of looking at it, but that's an assumption which I just wanted to check.
Yeah, I think, Jill, you want to come in?
I'm conscious of time for everyone, but this links to forward plan as well as a segue potentially, Chair. Just picking up on Jim's point and your point there, Graham, the 4 component parts of the strategy need to be seamless. So thinking about anchor institutions, as you've made reference to, large employers and mental wellbeing, that will come out in theme 4 that we hear about in December when Liz Robinson comes, and we are, if it's in our gift to do so, reframe wider determinants to the building blocks of good life. So I think we will hear that, and then it will be about how that dovetailing happens between mental health and inclusive employability and such like. So, and just to finish on that point, hopefully after we've heard the theme 4 in December, the intention is to bring the whole refresh strategy in with a new front end as well that will link the inequalities plan, but also that future direction of change in a generation will be the new forward to it in the March meeting.
Thank you very much, Jill. Any other comments? Thank you very much. So I think that will take us to the item number 7, Health and Wellbeing Board Forward Plan. I think Jill just gave us an overview of what I wanted to say. Thank you very much. So if there are any comments or suggestions, please email me or Jill or Leslie, please. We will be happy to take it on board in planning our future meetings. Urgent business, as far as I know, there is none, so which then brings us to the final item, which is the date of next meeting, which is on 14th December 2023. One of the items we will be discussing will be wider determinants, as we have already alluded to. Thank you very much all for attending this meeting. Have a good afternoon and a nice week. Thank you. Bye.